Good morning. Welcome to this, the inaugural taping of the Spotlight series. This series is intended to deliver insights into the management of atrial fibrillation and will run coincidentally with major international meetings. We're in Boston, in Massachusetts, for the 13th running of the Boston AF meeting. And we're here to talk about the development of cryoablation in atrial fibrillation. I'd like to introduce you to my distinguished friends. On my immediate left, Karl-Heinz Cook, Professor of Cardiology and Head of Cardiology at St. Georg Hospital in Hamburg, and Professor Heinz Pitschner from the Kirchhoff Clinic in Bad Neuheim. Both of these gentlemen have enormous experience in catheter ablation and significant experience in cryoablation using the Arctic Front balloon. And we're going to hear first of all from Heinz Pitschner, who will deliver the, I beg your pardon, we're going to hear first of all from Karl-Heinz Cook on my left, who's going to tell us about the treatment of atrial fibrillation with the cryo balloon. Karl-Heinz.
Thank you very much, Win. Good morning, everybody. Circumferential PV isolation has become the golden standard for catheter ablation of atrial fibrillation. However, there are some limitations of circumferential PV isolation, and it requires a lot of experience in understanding the anatomy of the left atrium. It's usually performed in conjunction with a reconstruction, three-dimensional reconstruction of the left atrium. It is a rather complex procedure due to the point-to-point burning around the pulmonary veins. The endpoint has been debated over many years, and still the debate goes on whether the pulmonary veins should be completely isolated or not. And finally, there is some potential risk of PV stenosis and atrioesophageal fistula using radiofrequency current. This is the approach which has been called the Hamburg approach, which is based on a three-dimensional reconstruction of the left atrium. In addition, we are using either the so-called double lasso technique or the single lasso technique to continuously record activity from the pulmonary veins. And finally, a circumferential big line is performed around the septal and the lateral pulmonary veins to completely isolate the pulmonary veins and the antrum region. Now, as mentioned before, that approach requires a lot of understanding of the anatomy of the heart. It's not easy to perform, particularly at the ridge, which separates the lateral pulmonary veins from the left atrial appendage. That ridge can be as narrow as 4 millimeters on average, and it's quite difficult to achieve a stable catheter position along this ridge part. Therefore, I personally believe that this type of sequential point-to-point burning to isolate the pulmonary veins will be restricted to only some very experienced centers and will not allow to treat the majority of patients with atrial fibrillation in the future. I believe that a unique anatomical approach with an EP endpoint, however, should be introduced to isolate the pulmonary veins. And finally, that strategy or technology should also allow for a rather low reconduction rate from the pulmonary veins to the left atrium, which ideally should be less than 10%. Therefore, we hypothesized whether a single big balloon approach using cryoenergy should lead to acute PV isolation at the junction between the left atrium and the pulmonary veins with no or a rather low complication rate, without using a second balloon or without using any kind of touch-up procedure, and without any pre- or intraprocedural imaging. We have chosen the biggest balloon which is available at this point in time, which is the 28 millimeter balloon, to make sure that we have a rather long distance from the phrenic nerve, particularly at the right side of the heart. And we also have paced continuously the phrenic nerve during any cryo application to the septal pulmonary veins. One requirement for successful isolation of the pulmonary veins is complete occlusion of the pulmonary veins. Therefore, for all of the application, a angiography of the pulmonary veins has been performed once the balloon has been positioned, and the freezing time that has been chosen in this study was 300 seconds per vein. This is the system, which consists of a steerable balloon and a steerable cheese, which is connected to the console, which is shown on the right side. Now, we have developed different ablation strategies for the different veins, in particular for the left-sided pulmonary veins and for the right inferior pulmonary vein. For the left-sided pulmonary veins, we're using a technique which we have called the so-called cross-talking technique. And as you can see in this diagram, there is some significant overlay of the big balloon for the left superior pulmonary vein and for the left inferior pulmonary vein. Therefore, we start always in the left superior pulmonary vein and deliver one cryo application to the left superior pulmonary vein, and irrespective of the result of that application, we move to the left inferior pulmonary vein and deliver the next application to the left inferior pulmonary vein when recording from the left superior pulmonary vein. This is shown on this slide. On the left side, you can see the cryo balloon sitting in the left superior pulmonary vein with a angiogram of the left pulmonary vein being performed, demonstrating complete occlusion by the balloon. The lasso catheter is simultaneously sitting in the left inferior pulmonary vein. And on the right side, you see the change of the two systems. Now the lasso catheter is sitting in the left superior pulmonary vein, and the balloon is occluding the left inferior pulmonary vein. Now on this slide, you see when the lasso is positioned in the left superior pulmonary vein, after one cryo application to the left superior pulmonary vein and change of the cryo balloon to the left inferior pulmonary vein, the recording, which comes from the left superior pulmonary vein, shows a significant delay of the pulmonary venous potential, then drop of the venous potential, and finally complete isolation with loss of the pulmonary venous spike. Now, for the right inferior pulmonary vein, we also have developed, depending on the individual anatomy of that vein, different strategies. The first one, which we try to perform in patients with early branching of the right inferior pulmonary vein, as is shown in this angiogram of the right inferior pulmonary vein, we use a technique which we have called the so-called hockey stick technique, with a wire deep in the inferior branch of this vein, as shown here, and the balloon then positioned in the superior inferior position. And again, the angiogram is performed to make sure that the vein is completely occluded. The second technique that we use in patients with late branching of the right inferior pulmonary vein, as shown in this slide, is called the so-called pull-back technique. The pull-back technique means that we start to apply cryo energy in this setup at the superior rim of the right inferior pulmonary vein, and after freezing at this part for more than 45 seconds, the balloon is pulled back to the inferior portion to occlude the gap, which you can easily see here from this angiogram at the inferior part. With this technique, we were quite successful in isolating this vein, and most recently we have introduced a technique which is called the so-called big loop technique. This is a technique that we use in those cases we are not successful, neither with the hockey stick nor with the pullback technique, to get isolation of the pulmonary vein. In this particular situation, as you can see, we are dealing with a rather inferior location of the right inferior pulmonary vein, and we make a big loop with the CryoCath catheter coming all the way from the lateral side down to the septal side, and finally being positioned in the right inferior pulmonary vein with a nice occlusion angiogram. Now, what are the complications that we have seen during this series? Now, first of all, phrenic nerve palsy is one of the major complications of all the balloon technology which has been reported. This slide demonstrates how carefully we try to map and understand the relationship between the phrenic nerve. As you can see here, we try to pace the phrenic nerve from the superior vena cava. In the red points indicate those sites where we capture the phrenic nerve. The green dots indicate those sites where we cannot capture the phrenic nerve. On the left side, you see a nice example of a rather posterior location of the phrenic nerve, whereas on the right side, you see a rather anterior location very close to the right superior pulmonary vein. Now, in this example, one of the complications of this series is shown. This is a patient in whom we try to isolate the right superior pulmonary vein. You can nicely see that the balloon is positioned at the antrum region outside the pulmonary vein with a nice occlusion angiogram. However, during the cryo application, there was a leakage between the connection of the catheter and the console, leading to a minor decrease of the size of the balloon, which finally slipped rather distally into the pulmonary vein and led to phrenic nerve palsy. Also, in the next case, as you can see, we were treating a rather big right superior pulmonary vein with a diameter of 27 millimeter. And for the 28 millimeter balloon, this vein was rather big, and there was a mismatch between the size of the pulmonary vein and the balloon, leading also to a transient damage. Very much like in this case, where we were treating a right inferior pulmonary vein, also of a size of 26 millimeters, with a rather distal positioning of the big balloon, leading also to some transient damage of the phrenic nerve. Now, overall, in this series, we have treated 26 patients with an average age of 56 years and a duration of the atrial fibrillation of 7 years. All of these patients had paroxysmal atrial fibrillation. There was a normal size of the left atrium, and only 5 patients had structural heart disease. Now, we could almost isolate all pulmonary veins using this single big balloon technique. In fact, we only failed in 2 patients to isolate the right inferior septal pulmonary vein. The fluoroscopy time was 56 minutes with a balloon time of 135 minutes. This rather complex slide should only show how many applications per vein were used. On average, for the left superior pulmonary vein, we used 2 applications of the cryoballoon. For the left inferior pulmonary vein, also 2 applications. For the right superior pulmonary vein, 2 applications, and for the right inferior pulmonary vein, on average 4 applications to completely isolate the pulmonary veins. As discussed before, there were 2 right inferior pulmonary veins at the rather early stage of our experience which we could not isolate. Now, one problem that we were facing throughout the follow-up of this study was that there were some recurrences of atrial fibrillation which were due to reconduction from the pulmonary veins to the left atrium. And as shown in this example of a cartoon map of the left atrium, 3 months after a successful acute isolation of the pulmonary veins using the cryoballoon technology, there was a rather wide gap along the posterior wall of the lateral pulmonary veins, and there was also a rather wide gap along the posterior inferior wall of the septal pulmonary veins that required multiple radiofrequency applications to finally re-isolate the pulmonary veins. So in total, we had 8 redo procedures out of the 26 patients, which is 23%. All of those patients who had recurrences of atrial fibrillation had reconduction from the pulmonary veins. We closed all of these gaps using radiofrequency count based on a 3-dimensional cartoon map. Preferentially, all the lesions were located along the posterior wall. And most interestingly, these gaps were rather large compared to gaps which we usually see following radiofrequency isolation. Therefore, we have initiated a new study, and that study is called the EXTRA study, and it's comparing, after successful cryo-isolation of the pulmonary veins, 1 extra bonus versus 2 extra boni in a randomized fashion. Now, I just can present some preliminary data of this ongoing study. As you can see, these patients are randomized after PV isolation to 1 extra bonus versus 2 extra boni. And for follow-up, we implant a Reveal XT to detect hopefully all recurrences of atrial fibrillation and or atrial tachycardia. Now, this is an example again of what has been discussed before. We're using the same technique. I just want to point out that in this example, we have previously, before the ablation procedure, implanted the Reveal XT system to guarantee a hopefully complete follow-up of these patients. Now, this is an example of what has been called the crosstalk technique to isolate the left pulmonary veins. As you can see, after 1 freeze of the left superior pulmonary vein, the left inferior pulmonary vein is treated with a lasso catheter being positioned in the left superior pulmonary vein. Again, there is a significant delay of the APV interval until complete disappearance of the PV spike in the left superior pulmonary vein. And the next slide shows very nicely an escape rhythm within the left superior pulmonary vein, indicating bidirectional block within the vein. Now, the Reveal XT system is a rather new technology which has been introduced recently. It guarantees 3 years lifetime of the battery. It's a rather small system. The recognition of atrial fibrillation or different types of atrial arrhythmias are based on an algorithm which is looking at the RR intervals. Patients can record by themselves, or an automatic recording can be initiated. If the recording is automatically initiated, it has a maximum of 27 minutes. If the patient activates the system, the recording time is 22 minutes. Now, this is an example of a implantation of this device. The device is implanted at the chest, and it's hardly to see after the implantation. This is an example of a recurrence of atrial fibrillation after a cryoballoon application. As you can see, there is clearly atrial fibrillation, which occurs during the follow-up period. On the lower panel, we see a stable sinus rhythm in the same patient. I don't want to go into details of this recording system. It's an early experience using that system. And of course, at that point in time, it needs visual control by the physician instead of just letting the diagnosis being done by the system itself. Now, as you can see in group 1 extra bonus, we have included so far 9 patients in the study. In group 2 extra boni, we have included 7 patients in the study. It's a normal atrial fibrillation population, again with a rather normal size of the left atrium. Now, we could isolate in group 1 33 out of 33 pulmonary veins, which is 100%. In group 2, 1 right inferior pulmonary vein could not be isolated, which led it to 96%. Again, the balloon time was comparable between the two groups, as well as the procedure time and fluoro time. This is the interim analysis, which shows that 2 out of the 9 patients had a recurrence over a rather short follow-up time of 71 days, which is 78%. In group 2 extra boni, we had a recurrence in also 2 out of the 7 patients, which leads to a rate of sinus rhythm of 71%, also during a rather short follow-up time of 73 days. So this is an ongoing study. But at that point in time, I would like to conclude that the single big balloon technology allows to acutely isolate the pulmonary veins in almost 100% of all patients. There seems to be, at this point in time, again, don't forget, it's a short follow-up time, small series of patients, no additional benefit of a 2 extra bonus strategy versus a 1 extra bonus strategy to reduce the recurrence rate in these patients. Thank you very much for your attention.
Thank you very much, Karl-Heinz. We'll have time for questions and discussions of the talk afterwards. But we move first of all to Heinz Pitchner's talk. Heinz has been interested in used cryoablation to treat arrhythmias for many years and probably has the world's greatest experience with the Arctic front balloon. So Heinz, we'd like to hear of that.
Thank you very much, Wim. Hello to everybody who was listening and looking to the presentation. What I want to share with you is the experience of a study we have started in 2004. A little bit later on to our center, the Heart Center from Bad Neustadt-Saale and Heart Center Bad Oeynhausen joined us. And the calculation basis of the study was very hard to do because we did not know at that moment how many patients we would need it because there was no experience with the cryoballoons on success rates. So we calculate non-inferiority to some other studies with radio frequency. And we wanted at that time to finish the study when we have 100 patients in a follow-up of 1 year. My disclosures first. Then I want to come to the inclusion criteria for this study. The age of the patients was between 18 and 75 years. They must have a history of 9 months of atrial fibrillation with 2 ECG documented episodes of atrial fibrillation last 3 months. There should be an unsuccessful treatment with at least 1 antiarrhythmic drug, no severe heart disease, and left ventricular ejection fraction more than 45%, and the parasternal axis of the left atrium in the echo should be not less than 45 millimeters. It's clear written consent. We have an ethic for this study and disposition of the patients to be followed for at least 1 year. The primary endpoints had been set as rate of targeted PV isolated, and we looked on documented AF recurrence of more than 30 seconds after a blanking period of 3 months. The documentation was obtained by a 7-day Holter ECG all 3 months, and the follow-up, you see a little bit later, was in step intervals of 3 months each. As a secondary endpoint, we choose safety, especially the complications acute, and which we could probably learn by 1 year follow-up in late complications. As I've mentioned, the follow-up was organized 3 months intervals, and we had in the second year 1 visit after 18 months, planned and 7-day Holter each 3 months, control of any occasional ECG, which give us an information that beside the 7-day Holter, an episode of atrial fibrillation started, and control of symptoms, control of medication. And in this study, because we have no idea at that time that PV stenosis is excluded by this cryo technique, we did a MRI and measured the PV diameters before and at the visit up to 12 months. The catheter material we used in the study in the first 10 patients, it was a 21.5 millimeter balloon, and in the case of this balloon we have no steerable sheet, so it was a heavy job to do the applications with its cryo balloon in the first 10 patients. But after this we had the 23 and the 28 millimeter balloons, as Karl-Heinz has mentioned before, and we had a steerable sheet, and that was a great help to do the job. And the electrical endpoint was isolation of the vein obtained by the lasso catheter. You can see it here, before and after ablation, and if there was a gap, we can't close with the 1 balloon or 2 balloons. Also the help of this linear catheter the freezer max catheter from CryoCath was allowed. So that's, I want to go through some angiographies with you. That the right upper pulmonary vein, you can see here, we inject the contrast medium, and we attempt a full occlusion of the vein, that no contrast medium can come out into the left atrium. And the next, please, you will see that the middle lobe here, which is rather on borderline to be an accessory middle lobe vein, you can see the upper vein and the upper branch of the upper septal pulmonary vein. Both are occluded here, and that gives you an idea, if you have the guide wire in different branches of one vein, that you can attach with a balloon different parts of the antrum, so that you can increase your antrum efficacy of the balloon with this technique, having the guide wire in different branches. And a typical problem might be seen, maybe seen here. It's the inferior branch of the right inferior vein. The upper branch is occluded and it's short branching, and sometimes we have a problem, as Karl-Heinz has described it, to get the inferior part of the ostial side. You see that the contrast medium is flowing out there, and the just described technique of pulling down after a freezing time of 40 or 50 seconds is just appropriate in most of the cases to solve this problem. Please, can you continue by hand? So in general, as I've described it, we followed a strategy that we want to have an overlap of the at the antral sides of the pulmonary vein ipsilaterally, so we can create an ipsilateral block isolation, and in most of the cases, indeed, that was possible using the 28 millimeter balloon. That's an example of a three-dimensional mapping. That's a NAVEX map. And you see on the left side, we use a 28 millimeter balloon, that a great area, a large area around the pulmonary veins in this case, is ablated. Also the space between the veins on the left side and on the right side, that's possible in more than 80% following our experience. That's an example. In the upper you can see the use of a 23 millimeter balloon on the left side. On the right side is a resulting ablation area, and you clearly can see that with a 23 millimeter balloon you got less antrum. That's more or less a circumferential isolation of the ostial sides of the vein. And again, example with a 28 millimeter balloon down on the screen, and again you can see that you can capture with a 28 millimeter balloon more parts of the antrum, and you have a nice junction of ablated area between the upper and the inferior pulmonary veins. Let us come back to the study. Here are the baseline characteristics of the patients. I only want to mention, looking on that there was a clear difference. Please look to the short axis and longitudinal axis of the left atrium between two cohorts. One is a cohort on the left side with patients with paroxysmal atrial fibrillation, and on the right side we have 53 patients with persistent atrial fibrillation. And as you can expect, there was a difference, significant difference in both cohorts regarding the dimensions of the left atrium. Let me come to the acute results. We find with the angiography and the MRI in the patients, common osteomas on the left side in 14 accessory pulmonary veins on the right side in 5 patients, and we were able with the technique described to isolate 98% of the targeted pulmonary veins. The cryo time for one vein in mean was 68 minutes, and the fluoroscopy time for the total procedure in mean was 45.8 minutes. The procedure time, it's 2.9 hours. However, I believe there's a lot of early experience in it, and there's also a lot of time-consuming work with the 3D mapping systems. So the experienced guys, I think, will come down to a little bit more than 2 hours to do the procedure. What about the use of the balloons in that study? Primary approach with a 28 millimeter balloon was in 66% of the patients. The investigators decided to change to a 23 millimeter balloon because they had problems with a big balloon in 7% and take it additionally. Primary approach with a 23 millimeter balloon depends on the diameters measured in the MR angiographies. 34% was chosen as a first choice, and secondary choice was 28, only in 3% of the cases that were mainly patients where we have seen that we were at the beginning of a phrenic nerve palsy, and so we changed the balloon in the right upper pulmonary vein to a larger one if the small one was chosen as a primary choice. Freezer Max, that's a linear catheter, was used in addition in 11%. And that is the most important result, I think, the long-term follow-up in this study. On the x-axis, you can see the number of patients primarily included. It were 346 for the procedure. We lost some patients. 11 patients were lost during follow-up because they denied to come to the visits or have missed more than 2 7-day holters. There were another 5 patients which get medication during the study, unwanted medication from the out-of-hospital doctors who took care for them. They were excluded from the analysis. And you see at 6 months, 9 months, 12 months, and 18 months, the number of patients on which the Kaplan-Meier calculation is done. What is obvious, we had after 18 months with 38 patients in, for the first endpoint, less than 30 seconds of a FIB documented in 7-day holter, 70.4%, and I believe that's a respectable result, absolutely comparable to radiofrequency ablation. The results were worse regard to the persistent atrial fibrillation. However, if you critically look into the literature and you take those centers on which reports you can rely heavily, it's nearly the same or in the range of that what you get with for patients with persistent atrial fibrillation with radiofrequency. However, the problem is with the current technology. If you must do a second ablation, we were not able to create long linear lesions because it's too much time consuming with the material which you have available at the moment. Coming to the diameters of the pulmonary veins, that's a box plot. That means the bars are the IQR 75 and 25. The end of the small lines is the minimum and the maximum, and the line in the middle is the median. And what we experienced, that there was no case of pulmonary stenosis. If you define it, we did it in an earlier MRI work published in Circulation of less or more than 30% change coming to the baseline, comparing to the baseline. Secondary endpoints, the complications, we have 2 pericardial effusions with 0.2%, and it seemed to be, as Karl-Heinz has mentioned before, a specific problem of balloon ablations, that there is a much more pronounced risk to have especially right phrenical nerve palsy compared to radiofrequency. We had 26 right phrenical nerve palsies during the studies. That means 75% overall. But there was one special thing to be mentioned. There were only 2 of them with the use of a 28 millimeter balloon, and one recurred immediately after stopping the application of cryoenergy. That clearly demonstrates that also from this aspect, the choice of the big balloon may be a primarily good choice in the future to do these cases. 2 cases had a hemoptysis, but we think they were related to a very stiff guide wire, primarily used in one center and not directly related to the balloon. The balloon in this cases was not inflated within the vein, which could be also cause for the bleeding of hemoptysis. 2 cases of air embolism with asthmatic intermittent ST segment, depression, not elevation. Elevation is right, related to the sheets. I think that's 0.2. And 2 cases, and that's another interesting point, only 2 cases of left atrial flutter occurring within 3 months after the procedure. Compared such complex atrium ablations with radiofrequency, that's a very low number. With radiofrequency, if you do additional lines, you can expect in most of the literature published something between 8% up to 20% of the cases. We have observed no PV stenosis, no atrioesophageal fistula, and I must state here that the number worldwide of patients treated and veins is statistically not enough to exclude for the future anyway this complication. However, also from the animal studies and experience before with the Arctic circle with ablation within the vein, we do believe that will not a problem in the future. The same is true for the atrioesophageal fistula. Let me conclude. The long-term results of PVI with cryoballoon ablation in patients with paroxysmal atrial fibrillation are comparable with radiofrequency ablation. The procedure is very safe regarding typical issues as PV stenosis and life-threatening atrioesophageal fistula. A specific complication is the right phrenical nerve palsy. I think the occurrence can be reduced by ablation with a 28 millimeter balloon and by consequent pacing from the high right atrium or a very deep pressing all 10 seconds. Patients with persistent atrial fibrillation at the moment are not appropriate candidates because we have no technology to create long linear lesions in a reasonable time. Thank you very much for your attendance.
Thank you very much, Heinz. We've got some time for questions now. This is obviously a new and exciting technique compared with the standard of radiofrequency ablation. Tell me, Heinz, first, how would you choose between the cryoablation and radiofrequency? What would influence your choice of therapy for a patient with AF?
I think if we want to go to fulfill the demand in the moment of patients who wanted, and doctors who wanted to have ablated their patients, it's impossible to use only a very intriguing technology like stereotaxis and three-dimensional mapping systems. What we need is something what is easy to do, and my experience was that it was much easier to bring up a young colleague to experience and to be able to do it alone with the cryoballoon technology compared, for example, especially in persistent atrial fibrillation, doing a good radiofrequency ablation. That's one point, and I'm very sure we did the three-dimensional mapping because it was the first experience. It's not needed. So what you can do is a simple procedure, as Karl-Heinz had mentioned, based on angiography, and if you are in a range over 70% of success, I would be very happy that if you go to the bottom of the of the truth in many publications with radio frequency. It's a good number, and a lot of patients can be easily be treated, much more easy compared to radio frequency ablation. And a good aspect also is the safety. I've demonstrated the safety of the procedure, and believe me, if in another 5 or 6 years the guideline committees are sitting together and will discuss if the ablation of antifibrillation may be a first-line indication, it's not only a question of success. I think the guys will not be interested. You have 90% or 87 or 83. I think the most severe aspect will be the safety of the procedure, the possible life-threatening complications, and there we have a very good low profile with the cryoballoon ablation, I think.
Karl-Heinz, how do you choose between applying radiofrequency or cryo to a patient with AF ablation? What factors do you consider?
I think at that point in time, the most important factor is that these patients have paroxysmal atrial fibrillation and no significant dilatation of the left atrium. If they are rather healthy patients, the procedure, as we have discussed, is a straightforward, simple procedure with a very low risk of complications. So my preference will be in the near future to open what we call a balloon lab and to introduce to the lab those patients as a primary therapy who have paroxysmal atrial fibrillation, and to treat them first with the balloon, and only if they have a recurrence such as an atrial tachycardia or atrial fibrillation, where we try to understand what is causing the recurrence, we do a full electrophysiological study. But the first approach for paroxysmal patients with normal hearts, normal left atrium, will be the balloon approach.
Okay. And with respect to the balloon, the choice of balloon size, I'm, like you, a fan of the 28 millimeter balloon. Do you think that there's any role for the smaller balloon?
I don't see any role for a smaller balloon. I see a strong role for a bigger balloon, because as we have mentioned, the likelihood of phrenic nerve palsy is very high. It's unacceptably high at 7.5% or 10% with small balloons. That's a general problem. So I would not recommend to use a small balloon. And as you could see in our series, rather small series, we only got problems with the phrenic nerve when there was a mismatch between the size of the vein and the size of the balloon, irrespective whether we are only using the 28 millimeter balloon. We found if the relation between the vein and the balloon is less than 0.94%, then of course you take some risk of phrenic nerve palsy. So the balloon in veins that are as big as the 28 millimeter balloon should not be used. I think we need a bigger balloon for these big veins. Until we don't have it, I would not treat a vein anymore on the right side with a size of more than 26, 27 millimeters. That's the conclusion that I've drawn.
Heinz, your thoughts? I know that you started off using the smaller balloon rather more. You seem to have changed.
No. At our center, most of the smaller balloons are used. At the other two centers, we have more than 90%. There may be seldom cases where you may use it, like if you have this vein, the middle of vein on the right side, in the middle between and you can't get it with a big balloon. What I would like to have is something like a balloon which can be changed in shape and in dimension. That may be by something like a compliant balloon. It's not easy for the engineers to do that you can choose a certain diameter, maximum diameter of 32 or so, coming down to 25. And also the front part of the balloon must be changeable with one balloon, so that you can bring up by shortening the length axis of the balloon into a mushroom or something like that. Very heavy to slip in on the right side in the right upper pulmonary vein, I think. What we clearly can state at the moment, we have tools with which we can work, especially the 28 millimeter balloon, but it's not the end of cryotechnology development. We need more. And it's unbearable that we, sometimes in the beginning, we have to change 2 or 3 balloons in one patient. then we lose all the advantages the procedure can bring to the patient and to us.
We've spoken about the phrenic nerve, and we know that for whatever reason, when we deliver any energy with balloons, the phrenic nerve is more vulnerable when treating either of the right-sided veins. What precautions do you take? What techniques do you use to monitor phrenic nerve function?
I think the best is to pace on the high right atrium, the phrenic nerve. That's clear. That's one side. There are some patients, if you are not in general anesthesia, who are not fully sleeping. We have deep sedation in our lab in general. The patients are not sleeping, and some of them didn't like this. So you have to go for deep breathing. But in general, I think the best protective way is to have balloons with other shape and large diameter, as Karl-Heinz has mentioned, and that really bring it down, estimate to 1 or 2%. It's a specific complication. You never can rule out that it happened one day, but you can bring it down drastically with those steps we have discussed.
Karl-Heinz, do you have anything to add?
I just would like to add, that I also believe the first issue should be balloon size. The second issue is continuous spacing, as Hans Pitcher is saying. We have not seen a permanent damage to the phrenic nerve when we immediately stop the application, when the phrenic nerve cannot be captured anymore. So therefore, I think that we are on the rather safe side if we immediately stop the application, if we use the big balloon. If that complication rate, which can be dramatic for some patients, particularly young patients, who need the movement of the diaphragm to exercise. And therefore, I think we should put all words of caution that people don't go ahead using small balloons and that don't pace during the application. I think this is really a must. I don't see any other better way of doing it. We have used eyes to identify the proximity of the site of capturing the phrenic nerve and the ostium of the pulmonary veins, and we have used the MRI. We didn't find anything helpful except for the online pacing and of choosing the right, which is the big balloon.
In both of your cases, the recurrence rates are fairly low, and the reinvestigation is also in small numbers. But what do you find best predicts a good outcome from a freeze to a vein? Do you monitor the temperature? Do you pay much attention to it? What's your major consideration?
Yeah, actually, we are monitoring carefully the lowest temperature that we can achieve. My personal belief is that the temperature has to be low. I'm struggling with the company, and the company people are always telling me don't care for the temperature because it's approximate temperature. That might be correct for some of the pulmonary veins, but my impression is if we can reach temperatures below 40 degrees Celsius, we are on the good side. Whereas if I have temperatures in the range of 30, I've never seen that we really could isolate in general. That may happen in some cases, but in general I've never seen it. So I think the temperature is important. The problem is that so far we had problems to get that information out of the console. Now the software has been changed and we have access to the temperature monitoring after the application, so that we can make some correlations now with the outcome and the maximal temperature that can be achieved. And I'm personally convinced that that correlation does exist.
Hans, what's your feeling?
I think it's more or less rough correlation, but Karl-Heinz Cook is right. I think there's a borderline. We fixed it at minus 35 here, looking to the temperature and to the acute success to isolate a vein. However, it's really a proximal measurement, so it doesn't tell you anything about the tissue side. And for me, it's important that the balloon shape is created in a manner that the major part of the surface of the balloon is on the tissue side. If you have too much which is directed versus the middle of the left atrium and the blood side, you lose too much cryo capacity. You can deliver with a better shape to the tissue side. That's one thing which for me is very important in the future.
We're in a world where we have to account for what we do, especially with respect to budgets that we stick to. A comment about cost of these technologies, or this technology. Heinz, start with you.
Well, you know that in Germany we have the DRGs and the DIMDI and INEC who control this. And one of the inherent birth faults of the system is that they control costs but not quality. So my fear is in the future that a lot of centers, the GOs of the economical department tries to force the doctors to go back to one lasso catheter and recycled and an irrigated tip recycled. So you have cheap cost, but you have only around 55% success with this technology. Yeah? But the cost will come down. So especially in Germany, we have to fight. And if the catheters for atrial fibrillation ablation are more than 2,500 euros, you can run into a problem in the future, I think.
I think at the end of the day, of course, we will need a randomized trial between circumferential PV isolation using radiofrequency and the direct cryoablation approach. And we need that trial not only for efficacy and complications, but also for cost effectiveness. My personal feeling is, and therefore we developed this, what we call the big single balloon technique, because we have abandoned 3D mapping for that procedure. We have abandoned any kind of imaging, MRI or CT imaging or ICE intraprocedural imaging. Therefore, I think if you calculate even the costs now and compare it to a radiofrequency procedure, the overall cost for the radiofrequency procedure with the mapping, with the three-dimensional technology, with taking care of the esophagus temperature and all that kind of stuff is about 7,000 euros in Germany. Now, the cost with a single straight big balloon technology would be around 3,500 euros. So, you know, it's a cut by 50%. But it needs to be proven, of course, the cost also for the follow-up needs to be taken into consideration, and all that needs to be studied rather soon than late in a randomized trial. And we are working on setting up such a trial, and hopefully this will give us some more insight also into the cost effectiveness of this, what I think is a very interesting and straightforward procedure.
What you've both described is a procedure that seems quite simple, straightforward, almost anatomical really, without much attention being paid to the electrophysiology. How do you see that? And also, interestingly, the results for different groups are virtually identical, which is different from radiofrequency, where there is a difference between levels of skill and the outcomes.
Yeah.
How do you see that influencing the evolution of this therapy? Do you think that's a positive aspect?
I think that is one of the requirements that we need actually to develop this technique of catheter ablation of atrial fibrillation further into patient populations to hopefully prevent one day that patients develop persistent or even chronic atrial fibrillation if we can intervene early in the disease when the patients still have persistent atrial fibrillation and no remodeling of the left atrium. I strongly believe that we can treat more and more patients and more effectively for the future to challenge the burden of atrial fibrillation for our society. So I personally believe the balloons will be a must for the future to be used to cover the big epidemiological problem of atrial fibrillation.
Heinz, do you agree?
Yes, I agree. I think about 30% of the patients starting with paroxysmal chorea will go to a persistent or permanent chorea later on with subset modification. And the pity is that at the moment we have no predictor who it will be. We have in an otherwise normal patient no predictor. He has in 10 years or 50 years permanent atrial fibrillation. He might have a problem, or he will have a problem with stroke or anticoagulation and bleeding. And I clearly believe that the earlier we can intervene without having life-threatening risk in the procedure, the better for the patient. Yeah? And I think that will be also the discussion in future for first-line therapy in atrial fibrillation, and I believe that the balloons will play an important role in this.
Thank you. Well, we're drawing to a close, but just finally, from this year's Boston AF meeting, what's your one highlight, Heinz, that you'd like to share with us very briefly?
If you
Only
ask
one.
If you ask me, as a technical interested guy, what is a dream to ablate from outside in a human heart? And that was with radiation beam and computer directed. Yeah. But I think at the moment this technology, if you look on the speciesisms that demonstrated, yeah, you have heavily fibrosis. I do not know if it is wished, if it is a little bit too near to the pulmonary vein osteomus, so it can create stenosis. But beside all the other technique processes, that's something like Raumschiff Enterprise, yeah, when Pille comes with his small stick and from outside heals the patients. Yeah.
Yes, well, from dreams into reality. Karl-Heinz, you're...
Yeah, let me come back a little bit more to the reality. And I'm continuously impressed by all the work that is done to prevent complications. So I think that's the major issue, as Hans Pitcher mentioned before. We're not talking about a malignant disease. We're talking about something which is affecting the quality of life of many of our patients. So we have to make sure that this is safe. People are talking extensively about how to prevent fistula, how to prevent PV stenosis and other significant complications. And I think that's the major message that meeting should take to the overall doctors, that they have to be extremely careful. We are dealing with a complicated intervention. It's not easy. Many people are using radiofrequency circumferential ablation. It's difficult to understand the anatomy, and we have to teach our younger colleagues that they have to learn to understand three-dimensional anatomy and to use radiofrequency current if they use it in the appropriate way. I think that's still, for me, what is fascinating me most at the meeting.
Well, gentlemen, we're running out of time. It remains just for me to thank you. Thank you, Heinz and Karl-Heinz, for excellent talks and your thoughts. And also to thank CryoCath for sponsoring this, the first in the Spotlight series. We hope there will be more. And so it remains for me to thank you all for your attention and wish you well and a good day. Bye-bye.
Bye-bye.